So this finding is here I can tell you the finding is seen on the mediastinal window. I'm going to scroll through. Good thought. Polychondritis is a very good differential. Plastica. Okay, you're just saying the part of the name. Okay. It's called as tracheobronchopathia osteochondroplastica. We call it as TPOP. That's a good one. So what we are seeing here is there is a osteocartilaginous nodules, or like ossified nodules in the tracheal wall, extending into the lumen of the trachea, sparing the posterior tracheal margin. When you see pathology is limited to the cartilaginous portion of the trachea, and especially if they have associated with thickening, you have very limited diagnosis. In this patient, because there is ossified nodules and it is extending into the lumen of the trachea, TPOP is the diagnosis here. Relapsing polychondritis can have a calcification, but it will never go into the lumen. It will be like a rim calcification kind of appearance and will be associated with exuberant thickening, not exuberant calcification. In this patient, you are seeing an exuberant amount of calcification. Other thing you need to be important, you need to be careful is when you see this in people more than 80 years, just don't even mention it. Just leave it like that unless the patient is having a broncholith within the airway causing airway obstruction. That is normal physiology. But when you see this in a middle-aged patient, and if the patient is on anticoagulants, always think of Coumadin trachea. So what happens in patient who consume Coumadin can have tracheal calcification. So the differentials for calcified nodules, relapsing polychondritis with smooth calcification, that is ossified cartilaginous nodules protruding into the trachea, you have to think of TPOP. If there is a young patient who has calcification and has a history of anticoagulant consumption, then you have to think of Coumadin related calcification.